Cough forming. Here, we present a rare case of primary paratesticular adenocarcinoma presenting as cough. Primary paratesticular adenocarcinoma is an extremely rare malignancy. Due to the lack of cases, they are often not on one's differential when presented with a patient with a scrotal mass. We aim to increase awareness of this tumor in hopes of reducing diagnostic delay and to emphasize the need for advancements in management options. We present a case of a 45-year-old male with a persistent dry cough for 6 months. His vital signs were normal, and initial physical exam was remarkable for diminished breath sounds in the lower left lung. CT of the chest showed diffuse reticulonodular opacities bilaterally with an enlarged mediastinal lymph node at the 4R station. For this reason, an EBUS with biopsy of the lung and 4R lymph node was performed, and the preliminary report suggested a possible thyroid malignancy. A thyroid ultrasound was completed and showed a normal thyroid gland but an enlarged superficial lymph node in the 4 station that was suspicious for thyroid carcinoma. After a follow-up discussion with the patient, he revealed that he was evaluated for a scrotal mass 1 year ago. At that time, he was told it was a cyst and no further workup was done. As a result, we performed a scrotal ultrasound at our facility which showed 2 extratesticular masses. After several weeks, final histochemical results from the biopsied lung and 4R lymph node returned. Following discussions at tumor board, it was concluded that the patient had metastatic paratesticular adenocarcinoma. As no treatment guidelines existed, the patient was enrolled in a clinical trial for rare genitourinary tumors called the ICONIC trial. The following section elaborates on the results necessary to determine diagnosis. Image 1 is the CT chest done on admission, which shows the enlarged 4R lymph node that was used in the immunohistological workup. Image 2 is the ultrasound depicting the 2 scrotal masses, one located superior to the testes and the other at the midpole originating outside of the testes. Table 1 summarizes the key immunohistochemical markers and results. Our working differential at the time included the most common malignant paratesticular tumors such as ovarian-type epithelial tumors, sarcomas, mesothelioma, and other secondary tumors. Our specimen stained positive for PAX8, WT1, CK7, and CA125, which are markers unique to ovarian-type epithelial tumors. Our specimen stained negative for calretinin and D240, which are markers strongly associated with mesothelioma. Negative markers for TTF and RCC meant thyroid and renal carcinoma was less likely. Lastly, normal serum AFP and beta-HCG ruled out primary testicular tumors. Image 3 shows the immunohistological images from the biopsied specimen. 3A is the 4R lymph node showing moderately differentiated adenocarcinoma with a micropapillary architecture. 3B is the lung specimen showing hyperchromatic and pleomorphic nuclei with a micropapillary architecture. Lastly, 3C, D, and E show the positive stains for PAX8, WT1, and CK7 respectively. The following section aims to further characterize primary paratesticular adenocarcinoma. This figure emphasizes how rare this tumor is compared to the prevalence of all other scrotal tumor. Primary testicular tumors make up the majority of all scrotal tumors, whereas paratesticular tumors only make up the remaining 30%. Within the subset of paratesticular tumors, 70% are benign and 30% are malignant. Within the subset of malignant paratesticular tumors, sarcomas make up 90%. The remaining 10% are categorized as miscellaneous paratesticular tumors. It is within this category our particular malignancy falls. Hence, it can be seen that primary paratesticular adenocarcinomas are extremely rare, making up less than 1% of all scrotal tumors. Table 2 summarizes key characteristics of this tumor based on extensive literature review. Majority of cases had an initial chief complaint of single, painless, scrotal mass, more often on right side. Many times a hydrocele, hematocele, or inguinoscrotal hernia obscures the mass, and it is not uncommon for these tumors to have already metastasized at the time of diagnosis. Given its rarity, primary paratesticular adenocarcinoma is a diagnosis of exclusion. Other common etiologies must be ruled out first. Pathology and immunochemical stains confirm the diagnosis. Unfortunately, the precise immunohistochemical profile is not well established and no standardized treatment guidelines exist for this malignancy. What we do know is that this malignancy is highly aggressive, responds poorly to commonly used chemotherapy agents, and overall prognosis is poor. Mortality within the first year can reach up to 40%, and 5-year survival rate is only 13%. To conclude this presentation, we will provide an update on our patient. Unfortunately, after enrolling in the ICONIC trial and completing multiple cycles of chemotherapy, there has been no regression of his cancer. His overall physical condition declined significantly, and he now requires continuous oral prednisone and supplemental oxygen for respiratory failure. According to his oncologist, his prognosis is poor, and the patient is now exploring palliative options. This concludes our ACP poster presentation.